I am very happy to talk about the topic that has been assigned, which is related to taking care of the baby in the delivery room who's born through meconium stained like. So without taking any more time on this, let us start with the topic at hand. And yeah, so I bring greetings from Lady Harding Medical College and from Kalavati Saran Children's Hospital, both these places. So Lady Harding is basically the college which is more than 100 years old now. And this was established in 1916 and we celebrated our centenary in 2016. So also Kalavati Saran Children's Hospital, high volume referral center, which was started in 1956 and it celebrated its 60th birth anniversary in 2016. So let's come to the topic at hand, delivery room management of neonates born through meconium stained amniotic fluid. The recent updates. So we all aware that meconium is nothing but it's from the Greek word called meconi, which means poppy juice or opium, which is a black tarry material. So this is actually something which is accumulating in the baby's gut from sometimes like at the end of the first trimester from 16-week onwards, and it is going on accumulating whatever the baby ingests. It could be lanugo, it could be some desquamated cells, bile salts and whatnot. So that is what makes the meconium. And whenever the baby passes meconium into the amniotic fluid, this is a sign of fetal stress. And this can happen in as many as 8 to 25% of live births. Among babies who are delivered through meconium stained amniotic fluid, there could be a few babies who are non-vigorous. What we mean by that is baby could be bradycardic, he could be floppy, he could have a tone which is low, and he could be gasping, or he would have a respiratory effort which is poor. So any of these three, if the baby is born through meconium stained amniotic fluid, would be labeled as a baby who's non-vigorous. So again, something like 15 to 25% of babies could actually be non-vigorous when they are born through meconium stained amniotic fluid. And about 3 to 5% of those born through meconium stained amniotic fluid would be the ones who are likely to develop meconium aspiration syndrome, which is something which all the neonatologists dread. So when a baby is born through meconium stained amniotic fluid, his fate could be, most of them often require resuscitation. They are at higher risk of meconium aspiration syndrome, air leaks, hypoxic ischemic encephalopathy, and even death. Some might require ECMO in the centers that have ECMO. Among the babies who are with meconium aspiration syndrome, if it is moderate to severe mass, about 50% of them might end up requiring respiratory support. About a third of them may develop air leaks. Similarly, a third of them could have pulmonary hypertension, long-term morbidities, respiratory morbidities in terms of the pulmonary reactivity in about 5% of them, and we could lose about 10% of such babies. So what is important is that during resuscitation, it is crucial to optimize ventilation and prevent further asphyxia and acidosis. A baby who is being born through meconium is already asphyxiated and maybe into acidosis. So that's important to remember, and we shall come back to it sometime later. So all of us neonatologists do not want the baby's lungs to have meconium into it. So we are very worried about the respiratory pathophysiology. And what happens is, if the meconium gets into the airways, it could cause obstruction leading to VQ mismatch, or leading to partial obstruction, which can cause air leaks. It can cause chemical pneumonitis, inflammation, surfactant dysfunction, which perpetuates the cycle of acidosis, hypoxemia, hypercapnia. It could cause pulmonary vasoconstriction and remodeling, leading to PPHN. And it has been lately known that meconium can induce apoptosis. So all the neonatologists are very varied of all these aspects, and hence they do not want that the meconium should enter the respiratory system or the airways. So there's been a lot of work that has gone mitigate not enter the system at the time of birth. So and immediate postnatal management of infants born through meconium stained amniotic fluid in the delivery room has undergone several changes over the last 5 decades. And when I say 5 decades, it's like from the 70s onwards till now, there has been a lot of change that has gone on, and we will go through that systematically. This has led to some confusion amongst the caregivers, also anxiety among healthcare providers as to whether they should adopt what has come anew or should they continue with what they've been already doing. So it's been a highly debated topic and we will go over it. So if you just want to look at the timeline from 74 to 2015, I haven't included 2020 as of now, which we will talk about towards the end of the talk. So there have been a lot of changes which have gone on at this timeline. But these haven't been something which is just out of the blue. There has been evolution of guidelines based on some evidence, which was true at that point of time. So in the early 60s and 70s, airway obstruction was thought to be the one causing mass. So airway obstruction had to be relieved. So in the 60s, what was recommended was routine endotracheal intubation for every baby born through meconium stain amniotic fluid. So this was based on prospective study by Gregory and a retrospective review by Ting and Brady. Thereafter, in 76, Carson came in and looked at intrapartum oropharyngeal suction along with the ET suctioning, which was already going on and which was a norm. So, and showed that there was much lower incidence of mass if both the things were done, which means if ET suctioning was continued and on top of that, IPOP was done. So there was five-fold reduction in the incidence of mass. This was not a randomized study. It was just on 273 babies, but then this was taken as standard of care and this was adopted that intrapartum oropharyngeal suction should be done. In the 80s and 90s, there were some conflicting results regarding endotracheal suctioning in babies with meconium stain amniotic fluid. Typically, the babies who were vigorous, although the term vigorous was not used by then, we are using it now. At that time, it was depressed neonate. So if the baby was not depressed, what the textbook second and third edition have acknowledged and have advised the healthcare workers is that probably non-depressed babies may not require endotracheal suction. So they had advised the providers to use clinical judgment in babies who were non-depressed, born through meconium stain amniotic. But all this was mostly based on observational studies. By this time, there was no ILCOR, and in 1992, ILCOR was formed. And ILCOR then took up this as an important topic to be addressed. And what was this topic? Management of infants born through meconium stain amniotic fluid and the prevention of mass. So if you just look at the timeline from 87, when the first edition of NRP was published, on to 1990, when the second edition was published, and then on every 5 years till 2020, which is now going to come. So in the first and second edition, what was advised was if the meconium is thin, watery, no special management is required. However, if the meconium is pea soup or thick, then you need to do IPOP as well as endotracheal suction. So the focus was on the consistency of meconium. Thereafter, in the third edition, intrapartum oropharyngeal suction had to be done. And if there was thin meconium with a depressed baby, do ET suction. Or if there was particulate meconium, do ET suction. So ET suction was kind of in this manner that it was conditional. Thin meconium with a depressed baby, do it. Thick meconium, do it anyways. And then came the fourth edition and so on. So ET suctioning in vigorous babies was the first thing that was studied by Wiswell et al. In the year 2000. This was a multi-centric RCT with 12 centers, more than 2,000 babies, term babies, ET suction versus no ET suction, but this is in vigorous babies, all right? So they found no difference in the incidence of mass, 3% versus 2.7%, and so also other respiratory disorders. And they concluded that ET suction amongst vigorous babies did not confer any benefits. And soon thereafter, the next year, there was a Cochrane review by Halliday et al., which included 4 small RCTs, including the one by Wiswell, which had the highest weightage. And they found that, again, no difference in mortality and morbidities, whether it was mass or other respiratory disorders or pneumothorax or oxygen need or HIE between the ones who were intubated vis-a-vis the ones who were not intubated. So then routine intubation and suctioning was not recommended for vigorous infants. This was the change that came in 2000. And so the guidelines changed in the year 2000. Routine intubation and suctioning not recommended for vigorous babies born through meconium stain amniotic fluid. However, the intrapartum oropharyngeal suction at the delivery of the baby's head before the delivery of anterior shoulder continued to be done. Now coming to the routine IPOP that was done. So in 2004, there was a very good study by Wayne et al. From Argentina, and he looked at multicentric trial with 2,500 babies, all term babies, from 12 centers, 11 in Argentina, one in the US. And he compared intrapartum oropharyngeal suction with no intrapartum oropharyngeal suction. And his primary outcome was incidence of mass. And he showed that there was no difference in the incidence of mass. Please note the numbers, 4% vis-a-vis 3.7%. And no difference in others as well. Since this was a well done study with adequate numbers, so routine intrapartum oropharyngeal suction in term babies born through meconium stain amniotic fluid did not prevent mass, and this was adopted in the 2005 NRP guidelines that it is not recommended. So sure, it is not recommended, but many of us on the other side of the world, which is the developing world, were not quite convinced with what was being proposed based on the study done in Argentina and the US, which we felt were developed nations, or the studies were done in centers in the developed nations. So then we had a question that routine IPOP in babies born through meconium stain amniotic fluid in developing country, what would be the scenario? So we all kind of believed that doing IPOP will actually reduce mass in our setup. Why? Because we have a lot of late second stage arrival of mothers, a lot of unbooked pregnancies, inadequate antepartum fetal surveillance, and high incidence of ascending infections. So we were almost contemplating writing to ILCOR, but then we decided that we don't have any data to write to them. And obviously they would not believe it because there's no data. So we went ahead to do a study on intrapartum oropharyngeal suction in a developing country scenario. This was an RCT where there were 509 babies, all term babies. And similar to Wayne, we had looked at IPOP versus no IPOP. So primary outcome was incidence of mass, which was overall 16%, but no difference between the two groups, 15.8 vis-a-vis 16.4. And so also the other outcomes were not different. So although mass was to the tune of 16% in a developing country scenario, compared to 4% by Wayne et al. And 3% in Wiswell study, but intrapartum oropharyngeal suctioning as a modality did not help in reducing the incidence of mass. Although we did this study somewhere in 2008-9, but we could manage to get it published only by 2015 for various reasons. In 2017, there was a Cochrane review by John Foster et al. From Australia, who looked at 8 RCTs, and which included the RCTs which have already been shown. And there were 4,000 odd babies that were included. And she looked at IPOP versus no IPOP. And typically, there was no difference in any of the outcomes that were seen. So the conclusion of this Cochrane review was currently available evidence does not support the benefits or refutes the harm of routine oronasopharyngeal suction over no suction. And they advise that there should be more studies done on preterm babies as well as in babies who were born through thick particulate meconium. So that needed to be there to complete the spectrum of looking at IPOP, whether it helps or it does not help. Now let's come to the last thing, which is tracheal suctioning in non-vigorous babies born through meconium stain amniotic. So for a minute, kindly focus on the right panel. Meconium aspiration can occur both intrauterine, which is more common, which has been shown in many of the animal studies that it already occurs intrauterine as a reflection of the baby who's asphyxiated or the fetus that is asphyxiated. And it can also occur as a perinatal event. So if it is occurring as an intrauterine aspiration, which is more common, as I said, ET suction will not prevent mass because it's already in, but can delay resuscitation of an already compromised fetus who's acidotic and asphyxiated. In perinatal event, ET suction might be useful because positive pressure ventilation will then lead to distal migration of the meconium, which is there in the airway. But mind you, this has to be within that 2.2, 2.5 centimeter length of trachea that you have the meconium, which can be aspirated by doing ET suction. So if you focus on this picture, which is courtesy Satyan, who is one of the co-authors for this. So On the right side is what is being shown as inflammation, airway obstruction. All that is occurring because the meconium is already inside the lungs during intrauterine aspiration. So these are all the potential disadvantages. You could delay resuscitation and you could also cause bradycardia while you're trying to intubate or do laryngoscopy. The good side would be that if there is meconiums present within the trachea, it could be removed and the distal migration of that can be stopped. But then we need to know which are those babies who have it sitting there in the trachea, the meconium sitting in the trachea and it hasn't gone beyond. So if we delay resuscitation, which is what is being postulated by doing tracheal suctioning, then in an already compromised fetus with elevated PVR, we are causing further hypoxemia and acidosis, which is worsening the pulmonary vasoconstriction, leading to PPHN, which can be seen here with the right to left shunts that are already here, which are being potentiated because of hypoxia and acidosis. So presence of intrapulmonary anastomosis and the ventricular dysfunction leads to refractory hypoxemia. It has the potential to lead to refractory hypoxemia, which may subsequently not even respond to inhaled nitric oxide. So delaying resuscitation is something that needs to be kept in mind while ET suction is being attempted. And I may just add here that ET suction, laryngoscopy and intubation would take something like 30 seconds, 3 to 5 seconds for one attempt of suction, another attempt, another 3 to 5 seconds. And so easily resuscitation is being delayed or PPV is being delayed by something like 45 seconds to a minute if ET suction is being attempted. So the first of these studies, based on all the accumulated wisdom over the years that it is occurring in utero, the first study was done comparing ET suction vis-a-vis no ET suction in non-vigorous babies at Jipmer Pondicherry by Chetri et al. So this was the first study in 2015. This was published. 122 babies, all term babies born through meconium stained amniotic fluid, and they were non-vigorous. So they looked at the risk of mass, complications of mass and ET suction, mortality, and all the other usual outcomes that are to be looked at, in addition to neurodevelopmental outcome at 9 months. Incidence of mass in this study was 7.8% of total births, but there was no significant difference in the incidence of mass, 33 versus 31%. Again, note the difference from the Western world studies. HIE 31%, 28%, shock, PPN, and mortality. So none of them, there was any significant difference. And they concluded that the current practice of routine ET suctioning for non-vigorous neonates born through MSAF should be further evaluated. It may not be useful based on their small study that they had done, but which was the first study. Thereafter, there was another study where we included 175 non-vigorous babies and they were randomized to the two arms. Our incidence of meconium staining was 6.3% and mass was 26%, vis-a-vis 28%. Again, no difference in mortality, mass, or even severe mass. And all the other things like HIE, duration of hospitalization, mechanical ventilation, oxygenation, all of them were comparable. So we also felt that this needs to be evaluated in a large study, because when we were planning this study and when we got the sample size estimation done, we actually need something like 1120 babies per arm to be able to conclusively give this answer, which obviously was not possible in the time frame as a single center study. So then what did the COSTER, the international consensus on science and treatment recommendations related to this, what did it say? What was the treatment recommendation? So in 2015, the treatment recommendation was there is insufficient evidence to suggest routine tracheal intubation for suctioning of meconium in non-vigorous infants born through meconium stained amniotic fluid as opposed to tracheal intubation for suctioning. So there is insufficient evidence to suggest this practice. But what was more important, that was by the task force, they placed more value or more weightage on the values and the preferences as well as on avoidance of harm. So in avoidance of harm, they were looking at delays in providing PPV while one continued doing tracheal suctioning, vagal stimulation during laryngoscopy and intubation, leading to further bradycardia, potential harm of the procedure if the provider is not trained. Insufficient evidence for benefit of the intervention of routine ET suctioning that had been shown by the studies till now. So emphasis should be on initiating ventilation within the first minute of life in a baby who's non-breathing or has ineffective breathing. So this was the recommendation. And the AHA similarly said that skilled person in intubation should be there because these babies may require further depth of resuscitation. If the infant is vigorous, this was something important in 2015 guidelines. If the baby is vigorous, born through meconium state amniotic fluid, he could receive routine care on the mother's abdomen. If he was non-vigorous, he goes through initial steps followed by PPV if the baby is requiring PPV, if he has an indication for PPV. So this was graded as class 2B, level of evidence CLD. And I'll tell you what that means. So whenever there's something is graded as class 2B, it means the benefit is more than the risk. And that intervention can be considered for applying. When you say CLD, level of evidence, then it is low quality with limited data. So obviously the data was much limited than what was required and the evidence was low quality. We'll come back to this low quality in a while, why this was graded as low quality. So then the seventh, non-vigorous infants born through meconium state amniotic fluid. Recently, again from our own country, we had two more studies, one in 2018. Hello, can you hear me? One in 2018 by Singh et al. From KGMC Lucknow. Okay, so they incidence was 9% meconium staining, and they had mass incidence of 41% versus 57%. We may have some differences in the definitions for mass, but we can leave that for a moment. So the interesting finding in this study was that ET suction, the intervention, tended to decrease the incidence of mass, which means it was helpful and tended to decrease the incidence, the duration of stay. However, overall incidence of respiratory distress and mortality remained unchanged. So there was trend to less meconium aspiration syndrome if the baby was suctioned, but that wasn't significant. The last study in this line was by Kumar et al. From BHU Varanasi, again from our own country, 132 babies, that's non-vigorous, and their incidence of meconium staining was 12%. So you can see from something like 7.8% in the JIPMER study to 6.1% in our study to 9 point some percent in the study at KGMC and 12% in the study at Varanasi. So meconium staining was within this range, and all these four institutions are reference institutions. Again, they found no significant difference in the incidence of mass, 30. So the mass actually ranged from something like 25 to 33% in all these four studies, and all the other outcomes were also comparable. So they concluded routine ET suctioning at birth is not useful for preventing mass in non-vigorous neonates more than 34 weeks gestation. So by now we had these four studies, and now was the time that there were many commentaries, and most notably by Viswell et al., who had done work, if you remember, on endotracheal suction in vigorous babies. And the commentary was saying that changing guidelines in this manner should not be the way. We should have a randomized trial of appropriate sample size, which should be done. And then the guidelines should be changed. So that was one of the commentaries, and there were other work that was done. Since RCTs to this level were not feasible or were not being planned, some of the investigators went ahead to look at pre and post era, because the guidelines had come in 2015-16, and subsequent to that, some more time had passed. So some people looked at pre and post. So let's look at some of these studies. The first one is by Chiruvolu et al. From Texas. So they looked at 4 centers, and they felt that they have been able to implement the guidelines very well, ET suctioning from 70% to 2%. What they found was NICU admissions for RD increased, respiratory distress, need for oxygen therapy increased, need for mechanical ventilation also increased, and the babies receiving surfactant also increased. The need for surfactant also increased, but many of the other things remain unchanged, like HIE, ECMO, use of INO, and so on and so forth. So many of the other outcomes are similar. So they concluded that recent NRP guidelines are not associated with increased incidence of mass per se, but was associated with an increased NICU admissions for respiratory issues. So that was the first of the study that was published, where they had some indication that you could have more babies getting admitted for respiratory distress. And at the same time was the commentary by Wiswell et al., where he said that this has been probably done prematurely without adequate evidence. Then there are two more such studies which were done by. One was from this was from the Vermont Oxford network, and where 311 centers were the one centers which contribute the data to Vermont Oxford network. So what they've done is they've taken the data from the electronic medical records. So it is not really looking at baby who is being born through meconium stain liquor and born as a non-vigorous baby and following that baby. No, it was on the other way around. NICU admissions for mass were being looked at, and is there a change after the National Resuscitation Program guideline change? So what they found was in this study, which was a huge number, and the babies who were admitted for mass were also quite high. This was the pre-era 2013 to 15, and this was the post-era 2017. So the incidence of mass reduced, which was significant, from 1.8% to 1.5%. Delivery room ET suctioning hadn't changed to that extent. It was almost just about half, and still about 30% babies did receive ET suctioning. And the explanation for that has been that the guideline change that occurs, and people who get trained, they will have their certification valid for 2 years. So some of the people who got trained towards the end of 2015 would still be continuing what was taught at that time, and they may still be continuing anyway, ET suctioning. Anyway, so they did not find, they found that surfactant replacement therapy did increase a little bit, but overall mass decreased. So NICU admission for mass and tracheal suctioning decreased with no subsequent increase in severe respiratory distress, was the finding by this study from the Vaughan network. There was a small study from Saudi Arabia. They looked at, again, before and after, but then they looked at all babies through meconium state amniotic fluid. The numbers were pretty less, 261 in the first epoch, that was the whole of 16, and 159 in the second epoch, which was the whole of 2017. And they only looked at all babies through MSAF, not just non-vigorous babies. And their mass incidence was very low, and even babies who were non-vigorous were much lesser. Anyway, they concluded that post-implementation of new guidelines, fewer infants were intubated, and there was no difference in the rate of associated morbidities or mortality. Then there was this study from CPQCC, which is California Perinatal Quality Care Database. This was again similar to the Vaughan network, but this was from all over California with a huge birth cohort. And they again looked at 2013 to 15 as the pre-phase and 2017 as the post-phase. And they found that the incidence of mass reduced, which was significant. Delivery room intubations, again, as I said, hadn't reduced by as much, but they were lesser as compared to before. And they felt that the guidelines were still being implemented. Need for positive pressure need for non-invasive respiratory support went up, whereas we are not very clear on what happened to the invasive respiratory support. Others were comparable, and average duration of stay also reduced. So they concluded that there's no increase in the incidence and severity of mass following 2015 recommendations. The last one in this series of pre and post, this came from another part of the world. So all the others were from US, one was from Saudi. This was from Oxford, UK. And here they looked at August 15 to July 2016 as the pre-phase. And there was a washout phase of about 2 months in 16. And from October 16 to September 17 was the post phase. So in this, babies born through meconium stain amniotic fluid increased, which was significant. Even the non-vigorous babies increased, the proportion increased, which was again significant. ET suctioning had really been implemented, the guideline had been implemented, and as you can see, from somewhere around 94% to 7%. NICU admission of non-vigorous neonates with meconium stain amniotic fluid reduced quite significantly, as you can see, and this was significant. And they had looked at all babies more than 34 weeks. And the numbers were quite significant in terms of the numbers studied. And they reported no increase in incidence as well as severity of mass following 2015 recommendation. So now we have these 4, 5 pre and post studies, some clearly showing that there is no increase, some others showing that there is increase in respiratory support requirement, but not in terms of mass. And we should all understand this and take it with a little pinch of salt that before and after studies do have some issues or pitfalls. One is that historical controls are being used, so there is likelihood of bias. Second is that a lot of it is coming from the electronic medical records, which is retrospective, so we may or may not have full information on things. Differences in all such studies could be attributed to improvement in NICU practices. In some of the studies that you saw, there was no dramatic decrease in ET suctioning. So which means the implementation had not occurred by now completely, and the exact date of implementation of guidelines was variable across different centers. We also do not have information on timing of ET suctioning. Was it for providing PPV to the baby, or was it exclusively for clearing the airway of meconium? And we obviously do not have information on the skill of the provider. So these are some of the things. And the last one is data on all babies born through meconium stained amniotic fluid and all non-vigorous babies is obviously not there, because as we can understand, they are all pre and post and taken from electronic medical records. So what we have is the information on babies who are admitted to the NICU, born through meconium stained amniotic fluid, and from their records, whether they were non-vigorous or vigorous. So following this, there are a few systematic reviews. I will just go through them quickly. So the first systematic review is, okay, the first systematic review on ET suctioning in non-vigorous babies. This is by an author, so sorry, it's difficult to pronounce the name, from Bangkok, from Thailand. And this has been published in ADCFN, and this was published recently in January 2021. They looked at the 4 RCTs, all 4 done in our country. These are all single center studies, which I've already described in detail. And their primary outcome for the systematic review was incidence of mass. And they looked at all the other secondary outcomes, and they found no statistically significant difference in the incidence of mass. So they concluded that there is no statistically significant difference in the incidence of mass, but the certainty of evidence is low to very low. And they concluded that initiating endotracheal suction soon after birth in non-vigorous meconium stained infant may not alter their neonatal outcomes. So this was the first of the systematic review meta-analysis. Sorry, there is one more. Yeah, sorry. So this is the other meta-analysis and systematic review, which again looked at the same 4 RCTs, all of them we have already looked at. In addition, they looked at one observational study, which is the study by Chiruvalu et al. From Texas, the 4 centers. Although that is pre and post, it's an observational study, so the numbers from there were included. That was multicentric, as I said, 4 centers. They found, again, this review found no significant difference, but their primary outcome was not incidence of mass, that was survival to discharge. And this actually includes people from the ILCOR who decided to do this systematic review before the 2020 guidelines were to be published. And they looked at these 4 RCTs and one observational study. Anyway, their primary outcome was again, no significant difference observed in the survival at discharge. And all the other incidence of mass and all other things that they looked at were comparable. Their conclusion again was certainty of evidence is low to very low, and insufficient evidence to suggest routine immediate direct laryngoscopy with tracheal suction. So now there's little more clarity in terms of insufficient evidence to suggest doing endotracheal suction. And in the same series, where we've talked about this, in the same series, we registered a protocol with the Cochrane related to tracheal suction. And this was registered in 2017-18. And we have completed our review, and it is as updated as up to 25th November 2020. And we've included, as we have committed to include only RCTs, we've included the 4 RCTs which are from our country. We've already spoken about them. And our results, which have been submitted to Cochrane, is insufficient evidence in favor of or against tracheal suctioning for reducing the risk of every 1,000 new evidence is low. Similarly, the risk of death before discharge from the hospital was not different. It could be 22 fewer or 92 more per 1,000. So based on all this that was available with the ILCOR, what did they come up? They came up with, sorry. Their treatment recommendation was for non-vigorous newborns delivered through meconium stained amniotic fluid, we suggest against, this is important, we suggest against routine immediate direct laryngoscopy and suction compared to immediate resuscitation without direct laryngoscopy. Although it's a weak recommendation, there is low certainty of evidence, but it comes more direct in saying that it suggests against doing routine laryngoscopy and suctioning. What it also says is, since MSAF is a significant risk factor for receiving advanced resuscitation, we must have a person who is able to do endotracheal intubation and suctioning if required, or PPV as required. Again, the values, the preferences, and the ETT framework looked at, and they are more direct as compared to what was said in 2015. Certainty of evidence continues to be low or very low. The reason being, I've been saying this again and again, the reason being it's difficult to perform studies in the birthing suite in a baby who is compromised to this extent, and then you have something which is like blinded study. It's difficult in the delivery room or in an operation theater where such a baby is being born. So the person who is performing the intervention will know what is being done. So it can never, blinding and for other things goes low, and that even though the certainty of evidence may be low, it is downgraded to very low because of the aspects related to the conduction of such. Anyway, what's more important is avoidance of harm. That remains similar to what was there in 2015. Delay in providing PPV with tracheal suction, vagal stimulation during laryngoscopy, potential harm, especially if the provider is not trained. And in addition, there is insufficient evidence of benefit of this intervention, which is routine ET suctioning. So emphasis should be on initiating ventilation within the first minute of life rather than trying to do intubation. So what are our knowledge gaps? Knowledge gaps remain. We need additional RCs focus on non-vigorous in the developed world, 4%, 3%, as compared to us, where it is anywhere between 16% for MSAF, and in non-vigorous babies up to 30%. Settings with various level of healthcare resources, where you have just a single person doing resuscitation, and so on. Do the risk or benefit of intubation with tracheal suctioning vary with any subgroup? Gestation, post-term babies, preterm babies, 34 weeks and between 34 and 37 weeks. The thickness of meconium, which has always been something which behind the mind that is meconium causing the problem. Thickness of meconium. Operator experience. Do the benefits vary with any of these subgroups? And we also need to look at the long-term consequences in terms of neurodevelopmental behavior, and it is assessed with the value.
Sorry for the interruption. Ma'am will join very soon.
So am I audible now?
Ma'am, yeah, ma'am, you are visible and audible. Screen sharing you have to do, ma'am.
Yeah, 1 second. That's just the last slide. So I was just saying that after knowing the knowledge gaps, let me just conclude by looking at what has been the landmark trials that have changed the delivery room management of babies born through meconium state amniotic fluid. I5 looked at nearly 2,000 mothers, amnio infusion, and this was refuted to be of any help. Then Visual looked at tracheal suctioning in vigorous babies. This was again refuted to be of any help. Wayne looked at intrapartum oropharyngeal suction, and again this was refuted to be of any help. And finally, studies, whatever little they have contributed to science, but these are the ones that have made changes to the delivery room management of babies who are born through meconium state amniotic. That's all that I have. Thank you so much, and I'll be happy to take any questions.
Thank you so much, ma'am, for the wonderful deliberation. You had really taken us through the entire journey, starting from 1970s until 2021, how the studies were performed. And so it was very wonderful to hear from you. And at one point, we had a total of 80 participants listening to you, listening to your wonderful lecture. There are a few questions coming up, and I would like to ask you one by one. Kodandapani asks whether there has been any record in any of these studies of the skill level of health worker who did endotracheal suction. Ma'am?
Sushma, ma'am, your voice is not audible.
Lady Harding, I'm talking about, because there's so much clinical material within India, all these centers. But yes, the answer remains that no, it hasn't been reported, and probably it's not been reported because probably it's not been looked at.
Okay. Shaurya is asking, what is the impact of endotracheal suction on air leaks? Endotracheal suction in delivery room and air leaks. Has it been looked at, and do we know about it?
So, they all the studies, whatever has reported, they've reported on the babies who received endotracheal suction vis-a-vis no suction, and the overall air leaks in the two sides. So we can't incriminate, or one cannot incriminate as a scientist whether endotracheal suction increases air leaks or reduces air leaks. But yes, it has been reported in both the arms of the different studies, and it hasn't been any different. So what one can infer is that probably it does not lead to increased propensity for air leaks.
Varun Sharma is asking whether there is any role for antibiotics in managing meconium aspiration syndrome. When should we consider antibiotics in such cases?
So Varun, I would like that you look at one of the studies done by us, and that's been published in European Journal of Pediatrics, where we've looked at antibiotic vis-a-vis no antibiotic in babies born through meconium stained amniotic fluid and who are admitted to the who need to come to the NICU. So in these babies, we have looked at, this is the RCT, and there has been no increase in the number of infections in babies who did not receive antibiotics. So that was one of our first work where we tried to prove that prophylactic antibiotics in meconium stained babies is not required. Now, your question on when would they be required, that will be like any other baby where when you suspect because of any risk factors, you do a sepsis workup, and if that is positive, you are going to start antibiotics. So meconium per se, where people would say that meconium is a good culture medium for bacteria to grow, meconium can cause secondary bacterial infection and so on, or meconium reduces the immunity and hence infection can occur. So all those things that have been written somewhere and spoken about really have not been seen in the clinical scenario, and they don't stand much. So if you find that a baby has risk factors, do a sepsis workup, and if it shows something positive, because in any case, in the lungs, you will have some infiltrates, which can possibly be because of meconium and which may also occur because of secondary bacterial infection. But that's not what has been seen, that all such babies end up having secondary bacterial infection. So in our unit, at least, we will not start antibiotics to babies born through meconium stained amniotic fluid, even if they're admitted and receiving respiratory support.
Thank you, ma'am. There is another question asking about what is the role of surfactant in severe MAS. Do you think it is effective in babies with MAS on ventilator?
Yeah, so the current thought process related to this is that there is significant surfactant inactivation which is occurring in babies who have meconium aspiration syndrome and who are requiring respiratory support and not they are not just with conventional ventilation you're not able to manage them. So the babies who go on the ventilator have high settings are the ones where people are giving surfactant at the same dose as is being given for any other for RDS, but there are no protocols as to when and which baby who is a baby of mass should receive surfactant. In fact, to the youngsters, this would be one of the areas to work on, and to at least formulate some guideline or some kind of a protocol for using surfactant in babies with mass.
Thank you, ma'am. Mubashir is asking, has any one of the studies looked at the number of attempted ET suctions and the time duration taken for each attempt? You were mentioning about this during your lecture, like how long it might be delayed. He's asking number of attempted suctions.
So unfortunately, it's only given as 1 to 3 attempts or 1 to 2 attempts. They have not looked. There is no systematic way that somebody has looked at the number of attempts, and certainly not the duration that it takes, because you need to have something like a camera in the birthing suite or in the operation theater, and this is being recorded without the operator knowing that it is a continuous recording going on, and then it is analyzed. So that kind of setups, no. In Australia, they tried to do something like this, but not related to meconium. They have generally looked at the provider's ability in how much time is he able to do the initial steps, how much time does he take for doing an intubation, and so on. So they've looked at it from a different perspective, but not in babies with meconium. This is certainly needed because we need to know if the operator or the person who's doing intubation is adept at doing intubation, can do endotracheal suction or not. So this is an important thing because it depends on the skill. So, but we are moving away from that requirement. So it hasn't been studied, and I don't think people have intention, or there are any, at least I have not seen any registered protocols where somebody's trying to look at this.
Ma'am, in your presentation, you had clearly shown that the incidence of meconium aspiration syndrome has been really high in Indian or developing country settings as compared to what
Western world.
Be the reasons? Is it the maternal delays, or what is your opinion, ma'am?
Okay, so we postulated these things in the study where we did intrapartum oropharyngeal suction. We had postulated and I think I mentioned those 4 points here as well, that the mothers come late in the second stage, they are not booked with a birthing place, so there is no proper antenatal monitoring as well as intrapartum fetal monitoring. That's not happening. So many of these things may be because in the Western world, when you look at the studies in the 70s, they had a much higher incidence of meconium as compared to now. So what has improved there or what has changed there is the perinatal management of a lady who is delivering. So although there is evidence to say that intrapartum fetal monitoring has not made a change in HIE, but in our setup, I feel that probably it is the late arrival of the mothers not being monitored well, and they already have meconium which has been passed, and they are still going from one hospital to another or not reaching the hospital in time. And the baby is in that environment for a longer period. He has more propensity to gasp and to take in more meconium. So it is related to maternal care during the time of labor as compared to other things. But there may be a scenting infection, maybe another one, which because we obviously have much more colonization, not GBS, but the gram negatives. So which may also be a reason for more meconium being passed. I really don't have a clear answer, but these are all the postulations.
Sure, ma'am. Ma'am, we have a couple of more questions. What is the role of stomach wash in meconium stained uh, babies born through meconium stain?
Yeah. So whoever is asking this question, I'll again request this person to look at a study that we've done on about 550 babies where we've done gastric lavage vis-a-vis no gastric lavage, and the overall incidence of any vomiting, retching, or gastritis was much less. It is less than 10% whether you do it or not. So the procedure of doing a gastric lavage did not make any difference to this. So one is the incidence of this is much lower, retching, vomiting, etc. And two is doing gastric lavage doesn't help. So this has been published in a little long back, I think. I don't remember the year, but yes, this is also published, and we worked on that because many of the centers and hospitals would continue to do gastric lavage, and there was no way to tell them that don't do it. They'll say, who has studied this? So yes, it has been studied, and didn't find any difference in the incidence of vomiting and other things.
There is one more management question. Karunakar is asking that in babies who are depressed and born through meconium stained liquor and are revived after initial stimulation, so not requiring positive pressure ventilation. How do we manage these babies? Do they stay in labor room and we observe, or do we bring them to NICU for observation?
My very considered opinion is do not bring them to NICU for any observation. If there has to be an observation done, it should be by the mother's side, and you observe the baby there for the next 2 to 6 hours. If the baby is not requiring any oxygen, he has been revived. He did not even require bag and mask ventilation, as you just said. So then this baby is like any other baby who required just the initial steps and has come out after that.
There is one more question.
Sorry, let me just complete it.
Yes,
so in fact, at our center, if a baby requires positive pressure ventilation for less than 1 minute, we just observe that baby by the mother's side in the birthing suite, and the baby does not get admitted into the NICU for post-resuscitation care. So it's only when it is PPV more than 1 minute or anything more that the baby should be taken to the NICU. I mean, that is what we do, take the baby to NICU. And we've done some work on this, but it hasn't been published. We've looked at this in a systematic manner, but this hasn't been published. And we did not find that the babies subsequently, have a problem and then you need to rush them to the NICU. No.
Anil has a question on the use of steroids in meconium aspiration syndrome, whether there is any role.
I would not know about it, and no, I actually don't know. I don't have an answer to that. I mean, we don't use it, And I don't find anything in the literature also which says that it should be used. Of course, one might argue that there is inflammation occurring, so steroids might be of help. So it's worthwhile doing a study. Somebody whoever is asking can actually look at this and try and see if an RCT can be done on this, and see if it, I mean, prove or refute that it is useful or not useful.
There's another question. What is the role of CPAP in meconium aspiration syndrome? Maybe there is a worry that there is a higher risk for air leak. So if babies have respiratory distress, what should be the initial management?
Yeah, so the initial management should be non-invasive respiratory support. And there's a very good paper by Srinivas Murki and his group, which has been published in JAMA Pediatrics. And they have looked at giving non-invasive ventilation. In fact, actually CPAP to babies with mass. And they've shown that it is effective, it can be used. So just giving CPAP will not increase the air leaks. If it is unmonitored, if it is too much CPAP, then that might happen. So any baby with respiratory distress, irrespective of what is the reason for distress, if the baby has spontaneous respiration, he should be on non-invasive ventilation. Only if he requires to be intubated, then he should be on a invasive mechanical ventilation.
Thank you, ma'am. Thank you for highlighting that point that babies with distress and retractions can be put on CPAP. And there is another pertinent question regarding the conduct of future studies. You had mentioned that after your systematic review, you had concluded that we need more evidence on this aspect. So what is the future thought on such a multi-center trial, and what are the difficulties in performing such a trial?
Okay, difficulty at this juncture would be the guideline that has already come, that's one. The first and foremost is you require, as I said earlier, something like 1100. I mean, when we had calculated based on whatever was the baseline, 1120 in each arm. So you need close to 2400 babies in total. So multicentric study can be thought of, but with the guidelines being there for last 5 years, from 2015 to 2020, there is low quality evidence, there is less evidence, there is not adequate numbers, but the guidelines have come. So now doing an RCT, I'm not sure if there is that equipoise now as it was at the time, at an earlier time when there was nothing has been done on endotracheal suction. And let me also inform you that NIH tried to do this study multicentric with some of the centers from other countries, including ours, but they did not get funding from the NIH for doing such a study for various reasons. Maybe US doesn't have as much meconium, or they didn't want to fund it for whatever reason, or is it a very high stakes study, so they didn't want to fund it. So this was, I think about 2013-14 when this was going on, that NIH wanted to do this a funded study like this. But as of now, I think all of us, do we agree that we have changed our practice, or we are still continuing to do endotracheal suction? One way around is that we look at prospectively, when we are not doing endotracheal suction, what are the results that we are getting. Although the Western authors, as I said, Wiswell in particular, has still recommended a large appropriate sample size RCT to be done, come to a conclusive evidence on this. So if it is feasible, if it can be done, I'm not sure if anybody is going to stop that, but I've given you the scenario of what has been happening till now in the last 5-6 years.
There's one more question on CPAP, on HFNC versus oxygen prongs in MAS. Whether one would consider the HFNC in preference to oxygen.
I mean, oxygen by prongs can be given to a baby who doesn't have a lot of retractions or who doesn't require a lot of respiratory support. But when the baby is not, you're not able to manage by just using that, then any non-invasive support should be. So it's actually not related to meconium. It's all related to the amount of distress or the severity of distress that the baby has and the kind of modality that is to be used. Of course, there is no study on comparing HHFNC with CPAP or with some other modality in meconium. What we have is the study by Srinivas, which is on using CPAP in babies with meconium, which is also something very important to prove that yes, you can manage babies using CPAP.
Ma'am, there is another question on the consistency of meconium. People say thin meconium, thick meconium, hindwater meconium. Does it really have a meaning at this point, or any meconium is the same?
Yeah, I think there is still merit in looking at the meconium. At what stage of labor was the meconium passed? So if it was passed early, that means that baby has been distressed for a while. That's one. And second, pea soup meconium or thick meconium, there is still something going around that this kind of a meconium can cause more obstruction, more problems. So as I said, some of the authors have recommended to do studies looking at different types of scenarios, baby's gestation for one, and second was the consistency of meconium. If you ask the obstetrician, they would still be very hung up on the consistency of meconium and meconium occurring at what stage of labor. I mean, meconium being passed at what stage of labor. If it is just at the time when the baby is coming out, they'll be like, okay, it's just passed now. But if it is there for a while and they do ARM and they get meconium, that's what worries them. So I think there is still some merit in looking at the consistency as well as the timing of passage of meconium.
Okay, ma'am. Ma'am, there is another question, and this the attendee is asking. We often find babies with who are recovered from meconium aspiration syndrome continue to have tachypnea. Often they have persistent oxygen requirements, which can run for a week or so. In your experience, what is like? How often do you find such a scenario? What would you do?
Quite often, quite often. In fact, such babies continue to require a trickle of oxygen or maybe a little more for up to a week, 10 days, or even longer. But the point here for restraint is that, oh, he's having respiratory distress, he's continuing to require respiratory support. It could be some bacterial infection. Let me start antibiotics. That's where you really should have some caution that should be applied. And we have seen babies, in fact, many of them who continue to be tachypnic and they continue to require some oxygen even up to 10 days or well into the second week of life. So, and they are improving. They are taking feeds. Taking feeds meaning they are being fed. They are tolerating feeds, and rest everything is fine. Their perfusion is fine. They don't have abdominal distension. So there's no other sickness parameter that is seen in the baby. Just that they remain tachypnic and there may be minimal retractions which are going on. So that's part of meconium being cleared from the system. I would put it that way.
So does CRP really increase in meconium aspiration syndrome? Do we need to worry?
So if you keep looking at CRP every day, you will keep worrying about that. So don't link CRP. We know in asphyxia, in meconium, in all these situations, CRP will be increased because these are all situations where there is some amount of inflammation which is going on. But that CRP, if you have a number, it doesn't tell you that this is because of infection or it is because of meconium per se, or is it because of asphyxia, or is it because of something else? Just a cesarean section, doing some kind of a surgery that has happened, that will also elevate the CRP levels. So I'm not sure why you want to see them serially. You see them as a part of your sepsis workup. If you have 2-3 parameters which are positive, so don't give meconium any extra importance for sepsis other than any other baby that you would be evaluating for sepsis and treating for sepsis.
Sure. Ma'am, for residents, what would be some of the take-home points from for the management?
Management in delivery room?
Yes, in delivery room.
Okay, so in the delivery room, whenever a resident has got a call for a baby who's being delivered through meconium stained amniotic fluid, he should be adept at resuscitation. He should ensure that as for any other baby, it should be gentle resuscitation. And we should have a person who is confident of being able to intubate if the need arises. So currently what is being recommended is you intubate if you see a meconium lying there, or if there's a meconium plug which may be obstructing the airway. That is the time that you would need to do endotracheal intubation. Or if a baby is so asphyxiated that there is no respiratory effort, you would need to intubate him for the purpose of PPV after a while of bag and mask ventilation. So obviously the person who's attending the resuscitation should be adept through full steps or all the steps of resuscitation. So such babies can be quite severely asphyxiated or very limp, and they may go on to require up to chest compression. So we have to be adept. I mean, the person who's attending has to be adept at all steps of resuscitation. And we should have somebody who is available to help if a second person is required for resuscitation, which may be the situation if you require to go on to anything where you have to support the circulation.
Sure, ma'am. Ma'am, there are two management questions on Meconium aspiration syndrome, whether X-ray plays any role in the management of MAS, and if there is a hyperinflated chest with predominant air trapping, how would we manage ventilation?
Mm-hmm. So in Meconium, I mean, we are going into ventilation, which was not a part of today's thing. What we have to understand is that you have to give enough time for the baby to have exhalation. There should be no air trapping. So if you're already seeing a chest which is, as you said, hyper expanded, or there is air which is air trapping that you are able to perceive on the X-ray when there are so many rib spaces that are being seen, you have to be clear that you are giving enough time for exhalation, one. And two, you should not have a very high PEEP that is being given, because that PEEP remains throughout the respiratory cycle. PIP is only during inhalation. So PEEP should not be too high. And second thing, as I said earlier also, you have to look at TE. Are you giving enough time for exhalation? Fortunately, these babies are term babies, so they don't require a lot of respiratory rate. So you can manage them at something like 35, 40 as a respiratory rate, which gives you enough time in a minute to give a TI of 0.4, and you have a TE which can be extending to something like 1.1 second. So you have 2.5 times the TE if you have a TI of 0.4 and a rate of something like 40. So which is good enough. You have to give time for exhalation. Otherwise, there will be air trapping which will occur over a period of time, and you may suddenly have a baby who has air leak, which is in the form of pneumothorax, or they may go in for small little leaks like PIE, which doesn't happen in term babies or in meconium babies as much, but air leak can occur. So in ventilation, we have to take care of these aspects, that don't keep the rate too high and give enough time for expiration. Do not keep the PEEP high. PEEP can be just about normal, 4, 5. On the contrary, if you have a baby whose lung is not expanded as much, yeah, certainly go ahead on PEEP.
Thank you, ma'am. You have taken up all the questions and we are nearing 9:15. That was once again a very wonderful lecture. And I give it back to Nasreen Bano.
Thank you.
Thank you. I enjoyed it as much.
One more question from YouTube. Can we have country-specific guidelines rather than universal guidelines regarding meconium stain amniotic fluid babies management? Because there are significant differences. I think that's a very relevant question.
We have India NRP guidelines which have been prepared by our organizations, which is the National Neonatology Forum of India and the Indian Academy of Pediatrics. So they have collected together, looked at NRP guidelines for India, where we don't ask all those 3-4 questions which are there in the usual AAP NRP. We are just looking at, is the baby breathing or not, breathing or crying, and based on that we are moving ahead with resuscitation. Yeah, specifically for meconium, there hasn't been any change in the guideline compared to what the ILCOR says or what the AAP guidelines are. There has been a certain definite move for India-specific guidelines for when to stop resuscitation, when not to start resuscitation, and which are the questions to be asked, how to go ahead. Similarly, observational care, which had been removed from the AAP-NRP, still continues to figure in our Indian guidelines, where there is routine care, observational care, and post-resuscitation. But specific to Meconium, yes, there is nothing which is specific to Meconium in terms of India versus the rest of the guidelines. You are muted. Banu, you are muted. You need to unmute.
Yeah. I think that's all the questions, ma'am. Thank you for taking all the questions and answering them very patiently. Thank you, Sindhu ma'am, for chairing the session. We can conclude the session, I think, and I would like to thank all the delegates for joining today's webinar. I'm sure that all of you have enjoyed today's session. Ma'am, we have more than 100 delegates attending both on Zoom and YouTube, ma'am. Thank you and good night.
Thank you. Thank you and bye-bye.
Thank you. Thank you. Bye.
Thank you.